All right, everyone, good afternoon and welcome to our webinar on personal protective equipment for home-based care. It's not easy. This is the first in the 2020 COVID-19 webinar series by the Maryland Emergency Preparedness Network. And we're really pleased today that we're going to have Dr. Amy Schiffman join us as our main speaker. So hi, I'm Dr. Charlene Brown. I'm the CEO and founder of Learn Care Together, and I'm part of the team that is pulling this webinar together. So first, I want to thank the Maryland Department of Health, the Office of Preparedness and Response, for having the vision to support and launch this webinar series. We are very excited that the Maryland National Capital Home Care Association, known to many of you as MNCHA, and Learn Care Together have partnered to bring this webinar series to you. So I want to invite you, if you have joined this webinar but you aren't already a part of the Emergency Preparedness Network, this is your chance. This is the website right here on your screen. Please go ahead and sign up to join the mailing list, and you will be notified about all of the upcoming 14 additional webinars between now and the end of the year, all focused on helping the home-based care providers to cope with the COVID-19 pandemic. If you're not a member of MNCHA, you can go straight to the MNCHA website and sign up there as well to learn more about Maryland's premier home care association. Dr. Amy Schiffman is the Chief Medical Officer at JESA. It's a Jewish social service agency. It has both a hospice and home care agency serving Montgomery County. But Dr. Schiffman herself is a board certified emergency physician who founded a home-based primary care practice serving primarily frail elders in Maryland and DC. She's been a leader in terms of senior care and now is working as the Chief Medical Officer at JESA, where she's become the PPE czar essentially. So before JESA, she had founded and led Capital Coordinated Medicine, this home-based primary care practice that I mentioned. But now she is literally this wizard around PPE and has a very vigorous approach to how we should be thinking about the use of PPE in the context of home-based care. With that, I'm going to hand it over to Dr. Schiffman. Thank you so much. But wait, before I hand it over to Dr. Schiffman, I'm actually going to invite you to take a poll, and then Dr. Schiffman will review the results of those polls during the webinar. We'll just take a minute or two for you to answer some of these questions. It'll help us to learn a little bit more about you and what your concerns are and what brought you to this webinar. Okay, we'll give it a few more seconds before we wrap up the poll. Okay, let's close the poll. Dr. Schiffman, over to you. We're excited to hear your
Great.
talk.
All right, let me go ahead and I am going to share my screen. And we're going to do this. All right, does that look right to everybody? Can you see it?
It looks perfect.
Great. So first of all, thank you, Dr. Brown. I am so excited to be here. Many of you on this call probably know me in my prior role, but I feel really fortunate to have moved over to JESA. It's an amazing organization. And although I don't wish for it to become the focus of this talk, the multitudinous number of services that JESA offers is pretty exciting. Oh, it's not easy. Look at that. It doesn't even say the right thing. It's not easy. Let's change that right as we go into the presentation. So PPE for home-based care, it's not easy. The reason that I am so excited to be here. In addition to being at JESA, is that when I started, it was about 3 months ago, and COVID was just starting. It was just starting, and there was no way to understand that it was just going to explode and that we were going to need all this PPE. And when I started, I became the PPE czar. So I'm going to start moving forward, and we're going to learn a little bit about all the new challenges that I encountered when I started this new adventure. So Fauci basically said, if it looks like you're overreacting, you're probably doing the right thing. So by doing the right thing, that might actually mean being very difficult to staff, or very difficult to supply, or very difficult to pay for. So I think the important thing is, if it looks like you're overreacting, you're probably doing the right thing. And that's going to be the theme that's going to be interwoven through this presentation. I want to go through the poll results, and maybe Nussin, you can throw those up there. Okay, pretty interesting actually. So most folks here are from private duty. There's some home health, a small amount from hospice, hospital, care management, DME, and then there's some other. I'd be very interested to see what those others were. I'd love to see that almost 100% are supplying PPE to your staff. That's not, I think Dr. Brown and I were concerned that there's a lot of folks that are not supplying PPE. In terms of what are the biggest challenges, very interesting. Of course, it's cost, and we're going to talk about that as we go through this talk. All right, so let's get started. So what are the biggest challenges for PPE and home care? And I'm going to expand home care to mean hospice, home health, private duty, anybody that's sort of in the home, close touch, warm touches, that kind of thing. So we're going to go through what to use, what is the cost, and I'm just going to reflect on the costs that we've incurred here at JESA, communications with staff, distributions to staff, a new term if you've never heard it, it's called burn rate, and then client perception of using and having to be around somebody that is wearing what I would call full PPE, and some real life challenges. So let's jump right in. So what PPE to use? So when I was trying to envision how JESA was going to approach this for both the hospice, and that included the nurses, the social workers, the chaplains, the volunteers, the home health aides, and then on the premier side, what the aides were going to be wearing, I had to start with a premise. And my premise was, everyone has COVID. That's where I started, and that's where I'm going to end this talk as well, is I think the way that I approach this is that everyone has COVID. That means that the caregiver has COVID. That means that the client might have COVID. That means everybody, if they're in a facility's got COVID. If we start with that premise, then it really just sort of makes everything much easier. The whole point for the caregiver or for the nurse, the chaplain, the whomever is there, is don't get COVID and don't give anyone COVID. Because you really want to make sure that everybody that you are serving from your agency's perspective cannot look back and say, it's your fault, or it's your fault, or it's your fault that either I got it or I gave it. So I came from that approach, and for that reason, you're going to see that I chose a very conservative approach for our agency. I'm going to go through the different types of supplies that I chose to get, and they're all based on CDC guidelines. I didn't use my imagination so much, so I'm kind of like laughing that I'm sitting here. I could just basically thank the CDC for helping me to decide. So we went with N95 masks, or at the very beginning, we couldn't get N95 masks, so we got KN95 masks. Everyone wears a face shield. We use single-use only gowns, so anybody who's using those like washable gowns, that's not what we do. We use single-use only gowns. There are multiple types of gowns, and we went with only level 2 or above. We did not use level 1 gowns. And then of course, everyone wears gloves. So we created what we called a full packet. a full packet. So the full packet is an N95 mask, a face shield, a single-use gown, and gloves. That's what we call a full packet. And I'm going to refer back to this full packet several times during this talk. And then there was plus minus a mask on the client. And I will tell you as a general rule, we do not put masks on our clients. But there is some evidence that if you have somebody that's actively coughing, you may consider that. But we have not made that a standard within our own practice. Most of the folks that we take care of, probably like you guys, are frail, probably have some element of respiratory issues. It did not seem like a good choice for our particular practice. So I wanted to sort of start with this image, which is a sneeze, right? Like, look at all of this. These are aerosolized droplets, and inside of each one of those droplets is, lots and lots of viruses. Each virus is teeny, teeny, tiny. It's less than 0.1 microns. So even though those droplets are huge because they're like covered with like protein and carbohydrates, and then sort of like big glob of mucousy nastiness, there's a lot of things that are going to protect you from that if they're that size. But if we're looking at the little tiny virus themselves, you need to think to yourself, what is it that I need to do to protect my staff from either giving that to somebody or from getting it from having that happen to them? So it turns out that the CDC helped us out, just like I said, and I wanted to go through what a packet was through from the CDC, and that's basically what we used. So on the left-hand side is the preferred PPE, and you can see there's an N95 mask, face shield, the gloves, and an isolation gown. They have an acceptable alternative PPE if you cannot get the N95. And the only difference between what's on the right and what's on the left is that they're using what is like a medical surgical face mask. Again, it's not perfect, but they're saying it's an acceptable alternative. So we have opted for this side, the N95, mostly because we had access. We were able to get that supply. So let's just sort of finish up the discussion about exposures. It's a droplet exposure. You need an N95 or KN95 with a face shield. And remember that the exposure that folks who do home care usually have is a close-in contact. So you really don't want to be using just a medical mask unless there's no alternative, and definitely not cloth masks. So anybody who's sending their staff out with a cloth mask is probably not really protecting you're not protecting your caregiver. The cloth masks are really thought to protect for outgoing. It's sort of like, I'm going to protect you from me. The problem is that you're also closer than 6 feet for most of the activities, and it certainly does not protect them from a client that may or may not have COVID. And remember, my premise is everyone has COVID. So then there's, of course, the possible bodily fluid contact with droplets. And for that, you need a gown. I mean, remember, the virus can live for several days on surfaces. So you need gloves. And then if you're like somebody who's going to be, moving around their living space, you're also going to need the gown to protect yourself. So there's not a huge amount of data about virus and how it attaches to people's clothing, but I went for a very conservative approach. I said there's going to be a lot of personal care. People are going to have a lot of things that they're doing that are, putting them into contact with virus that's been around, potential bodily fluids, droplets. I want to protect everybody in the most judicious way that I possibly can. Additionally, we give out hand sanitizer and wipes, and we even give everybody a little bit of extra PPE. And I'm going to discuss a little bit about how I decided how much PPE to give everybody. It's based on my, a full packet that I was discussing before. But yeah, we give out hand sanitizer and wipes on a weekly basis for all of our hospice care, like our hospice nurses, anybody who's going out, we give them a week's worth at a time. And on the home care side, we are doing 2 weeks at a time. So communications with staff. So this is where I think really the culture of your agency is a driving force. Knowing how to reassure folks and train them is so meaningful, and we have felt it in some Zoom meetings we've had with our premier caregivers, is that They appreciate education, they appreciate training, and they appreciate reassurance. So on the training side, and I don't know how everybody does things, but we used a standardized training module through something called Relias. Now we use Relias through hospice, but we also, Relias has a ton of free PPE training for COVID right now. So if you're somebody that doesn't really know how to like go about training everybody and making it standardized and making sure that there is a way to track that, there are infection controls and doffing and donning modules inside of it, and you can ask your caregivers to do a screenshot of their phone or take a picture of something on a computer and send it back to you so that you're sure that they have undergone that training. And then of course, like everything else, I mean, I have to relearn how to, you know, record something on my DVR like all the time. So it's sort of like a repeat, repeat, repeat. Remember, this is staff that may or may not be using that information in their active memory. Repetition is always really great. So using standardized training, Relias, I'm like advertising for them. I wish they would probably send me something free. And then just utilizing the free COVID resources. That's just one option. And we've been doing that within our own agency. And as far as reassurance is concerned, I am quite sure that all of you have had trouble staffing at times, particularly even if you're like, oh, we're going to staff COVID cases. It may have been really difficult to find anybody who is even willing to staff those cases because there's fear, fear, fear. The staff is scared, right? They're going to go back and maybe give this to their loved ones. They're going to get sick themselves. There's a lot of difficulty with access to healthcare within some of the caregiving population. There's a lot of unique challenges within this workforce. And of course, they are the closest in with a lot of patients who are the highest risk. And for people who are going into nursing homes and assisted livings, that was probably a little bit more acute and right in your face. But I think that home-based clients, you know, people will go in and out of the hospital, they're coming back home. You know, this whole testing for COVID has only just now become really accessible. So at the very beginning, we had you know, some challenges with getting people to want to go out and see people, go out and be in people's homes. So there was a lot of fear, and that was expressed to the scheduling coordinators. I mean, everybody was hearing about it in the agency. It wasn't just, you know, they didn't keep it to themselves. They were able to express the fact, I am worried, I am scared. So there was a lot of, we had to do a lot of reassurance. We had to reassure people that we were providing them with the correct PPE, providing them with an adequate supply of PPE, that it wasn't, and it was not just a check mark. I mean, it was not a box that we just put a check in. This was something we really wanted our caregivers to feel reassured about, is that we were going to put their safety as a priority. So distribution, I am sure you've all, if you've started supplying PPE, it is a true logistical nightmare. Do you deliver it to the staff? If they're in a facility, do you deliver it to the facility and then maybe have somebody accidentally steal it? Do you deliver it to the client only to have maybe the client really not know what that is? They don't want something like that in the corner. Keeping tracking how much you have, tracking how much you've given out, to whom. Assuming makes an ass of you and me. I love that phrase, sorry. But basically assuming that they're going to come in and pick up their supplies, that's not a good solution. You know, it is really the responsibility of an agency to protect both their caregivers as well as their clients. So, you know, you don't ever want somebody to come back later and say, well, I mean, you didn't call me to remind me to come and pick that stuff up, or I didn't see it there, so I figured you didn't want me to have it. This is like yet a new responsibility that is kind of self-imposed. This is not regulated yet within the private duty world. It's actually not really even regulated in hospice yet. We haven't heard anybody come down from below and say, you have to do X, Y, and Z in the following way. We're really kind of creating some of those standards ourselves. So it really is the responsibility of the agency. And I will reflect and say, it's not a small FTE. You know, it's not a full FTE, but it's not a small amount of an FTE to manage all of this. Managing, you know, are we running out? How are we gonna give it out? Now, at JESSA, we've been really fortunate. We have got some amazing volunteers that have really put this together for us. We have a checkout system in like a library style. I mean, we don't want it back, but you know, people will say, I'm going to be doing this many visits this week. This is how much I need. This is what I'm going to need. And we've done a really good job educating our staff to know what is expected for each individual patient visit. And I will get into that in a second when I discuss cost. But yeah, it is an enormous responsibility of the agency, of your agency, that is an unexpected cost. So now you've got the additional cost of the PPE itself, plus now you have to manage it. So burn rate. Burn rate is a term, if you've never heard it, that's basically like, how quickly are you going through your PPE? This has been probably the biggest unique challenge when I first started at JESSA, is that we kept thinking, is this just, do we want to just buy 2 weeks worth? Should we just buy a month's worth? Like how to manage the costs of it, because it was so expensive at the get-go, but we knew it was going to keep going, but we didn't want to run out, and we didn't know how long things would take to come. And I think we were in a really silly spot at the beginning, and we just didn't really, it was so many moving parts. When I first started, I almost spent 6 hours a day trying to source stuff, and we do, you know, well over 1,500 touch points per week. So we needed an enormous number of PPE packets. So it became like a real thing. We couldn't order just 2 weeks at a time, because we actually were noticing that stuff we'd ordered in February before I even came hadn't even shown up yet by the middle of April. So there was a little panic feature going on there, where you're like, how am I going to keep up? How am I going to make sure that I can keep on top of it? So we created a lot of Excel spreadsheets to figure out what our burn rate looked like. And so on the hospice side, every single individual patient encounter, we made a choice within the agency to put together a full packet. So everybody got a brand new N95 mask, a brand new disposable gown, gloves, and we gave out face shields to people. I mean, that could be cleaned. But in terms of what we consider to be a packet, is that every individual patient encounter got the gown, the N95 mask, the gloves, and then of course they had their face shield. So that was a packet. So how many packets? It was basically how many visits are you going to, how many patient encounters are you going to do? We never had anybody leave them on while they were in a facility. They would even doff and don within a facility. At the beginning of all of this, we were seeing lots of COVID patients. I mean, we were in hospice, so we were seeing a lot of people who were end of life, who were actively shedding virus. So we wanted to make sure we didn't bring it from patient A to patient B. Now, on the other side for private duty, which I think is really important based on the information that I saw at the beginning, which is you guys are all in private duty, is I said to myself, you know, how often should a caregiver be changing their PPE? Like, you don't necessarily want somebody who has done some personal care to then not have an extra change during a shift. So we looked at each sort of 4-hour time slot as a single packet time. So we said, if you're going to see a client and you're going to be there for 8 hours, that's 2 packets. 12 hours, 3 packets. If you're just going to go there and do a little bit of personal care, that's still 1 packet, even if you're there for 30 minutes. So we basically, I'm calling them units or packets, whatever it is. It was 4 hours for private duty, and home health and hospice, it was unique patient. Well, we don't do home health, but in our hospice side, it was how many unique patient encounters were being done. And I think that sort of worked out pretty reasonably for us, because we were also able to quantify what our burn rate would look like, because we knew how many visits would be getting done. So when I looked at the cost, I mean, the costs are clearly coming down now. They are half of what they were 8-12 weeks ago. And I'm sure all of you are seeing that within your own balance sheets. But so I like to think about things in terms of unit economics. How much is it going to cost per patient encounter or per 4-hour period? So we basically, as I told you, we do, well over 1,000 in any given week. So that's lots and lots and lots. So I wanted to figure out how much it would cost based on our burn rate. And I also made some choices. I spent more at the beginning because I really did want to save time and aggravation later. Even though I think we may have paid more for the PPE, I over purchased so that I didn't have to think about it every single day. So here's what I wanted to show you guys. So based on the costs per unit, I think it's really helpful to think of it this way. I thought it was a cost per unit. So assuming that it was about $3 per mask, and of course now we're seeing those costs come down, but let's just say it was $3 per mask. Now there are some opportunities to reuse in some places where there's you don't have enough, but we did not at Jessa do that. We literally do kind of go with brand new every single time. So let's assume it was $3 per mask, $2.50 per gown. And then we had a $6 per face shield. I didn't count that in a per unit. And gloves, I think, are really hard to price out, as are the weekly costs of wipes and hand sanitizer. So I basically said that the cost of PPE per 4-hour unit or per unique patient encounter on the hospice side was about $5.50. That didn't count the face shield, like I said, and it doesn't take into account the gloves and the wipes and the hand sanitizer or the human costs of administration, distribution, keeping track of it all. So certainly you could look at the per unit cost and probably double it and say it's probably $10 just to keep track of all that stuff per unit 4-hour, or you could be reasonable, say maybe $7, somewheres around that. But at the bare minimum, it was no less than $5.50. And I don't know how many of you are passing that cost along to your clients, but it's impactful. It's very impactful financially. From a client perspective, the interesting thing that I discovered was this, is that the clients do not actually love to see their caregivers in PPE. It medicalizes the assistance that they were getting, which is really not considered to be medical care, right? It's sort of private duty. I call it the B&B, the buttons in the bath. There's a lot of things that are going on in that home. The CNA is not really considered to be medical, but here they are showing up in like a gown and a mask and a shield and gloves, and suddenly everybody feels like there's something wrong with them. The family is worried. The client is self-conscious. It's maybe going to cost them more. So, one of the things that I have spent some time, not a lot of time, but some time doing, is trying to explain to the caregivers and explain to some of the staff that has more frontline exposure to the families and that type of thing, and the clients themselves, is that we're going to have to kind of get over it for a little bit. We're in the middle of a pandemic. This is a very conservative approach. If somebody said to us, I'm not going to have you back in our house if you're going to wear that ridiculous outfit. Well, that's not going to be a client of ours anymore necessarily. Everybody has COVID. Back to the original premise, everyone has COVID. Now, I'm not saying this is a really popular approach, but it is going to be our approach, because the last thing I really want is for me or anybody on Jess's staff to give it to somebody, or for any of Jess's staff to get it. So this was a very conservative approach, and I think so far it's paid off. So let's talk about some of the real life challenges. This is expensive. PPE is really expensive. And I'm sure that at the beginning, although I'm not sure it's still such a problem, there were supply chain issues. Where do you get this stuff? I was literally calling, and I jokingly said this in a different presentation. I found a guy in West Palm Beach who usually imports pocketbooks from Saks Fifth Avenue, who then became my drug dealer for PPE. I'm going to contact him after this is all over, because I would really like some Saks Fifth Avenue pocketbooks. But in the meantime, I had to find people that could connect to anybody that would understand the import-export process, who maybe had a warehouse, understood the logistics of how to move stuff around. It was not easy at the beginning. It has gotten much easier, and of course we bought in bulk. So I made the decision to spend a lot of money up front, because I don't think this problem is going away. I do not think our staff love this, and unfortunately, I so empathize. I don't even know what to say, because they sometimes go into facilities that don't turn on the air conditioning, or homes where they're warm because their client likes it hot. And here they are sweating it out with the mask and the, the whole bit. It's a lot, but I don't have a great solution. I do know that some of our staff make choices, and we have had to talk to them and said, listen, here's the deal. This is what it is to work here. This is what it is to do this and that. Distribution is really challenging. Like I went back and said before, there's an administrative higher up that you have to think about. Like, you have to know that you got to manage the supply chain. You got to manage the distribution. You got to do all of these different things. It's very difficult to do all of those things at the same time, and does require an administrative back end. And requires repetitive check-ins. You got to be making sure that everybody's feeling reassured. Remember, fear is not going away. And so it's definitely something that is a unique challenge. I apologize for my dog barking. And there is a cost to the client, and that is going to affect your marketing. So, depending upon whether or not you choose to pass that along. So anyways, those are some of the real life challenges. I wanted to open it up to Q&A. I think we've covered a lot, but I know I didn't answer all the questions, so I figured we would go ahead and jump right into Q&A.
Wonderful. Thank you, Dr. Schiffman, for an amazing talk, sharing your experiences with PPE for home-based care. We have a couple of questions already in the queue, so I'll go ahead and get started. The first question is from Kathleen. How are you handling logistics and delivering PPE? Are you providing PPE to individual caregivers or to individual clients? Her agency has had issues with caregivers burning through PPE faster than allotted for.
Okay, so wow, there's a lot there. So I will tell you how we do it. We look 2 weeks ahead to see how many 4-hour sort of periods of time that individual is going to be out seeing clients. So that might be even if it's a short visit, like an hour, they get 1 packet. If it's a 4-hour, they get 1 packet. If it exceeds 4 hours, we go into the 2 packet, so that we count how many sort of like 4-hour units, or short, like if it's less than 4, it's 1. If it's greater than 4, it's 2. I'm not doing a great job explaining that. But anyway, so you count how many of those in advance, you put together a whole thing. And we actually have had the caregivers stop by the office to pick it up. We have the benefit of having, that we have a little transportation service within JESA called Brenner that usually does patient door-through-door patients. We've been able to get them to drop stuff off. It's been a big team effort too. Like, we know if somebody lives near somebody, they can also drop it off. We have some of our staff sometimes drop it off where they are. It is, right, it's like pure chaos, but it has to be managed, and you have to have somebody that kind of takes ownership of that within your organization. You have to say to yourself, somebody's got to be your PPE czar. They've got to just take it, take that bull by the horns and just know where it's got to be, how much has got to be there. And that's just the only way I think you can probably do it. Now, let me see if I can find how are you handling logistics. Okay, yeah, so we give it to the caregivers. We have tried it both ways. It depends on the client. We have mixed it up a little bit. And in terms of the caregivers burning through the PPE faster, I think personally from that description, we told them how much we expected for them to use. We actually give them a little bit more. I say that it's a 4-hour, and we give them for anything over 4 hours, we will give them, an extra mask or an extra gown. We don't want them to ever run out. So we kind of give them a little bit of extra, and I've sort of planned that. So there's a little bit of a buffer. It's like, you don't want them to get soiled and then not have a supply. So you might want to give a couple of extras, but if they keep it with them, they can bring it to their next client, it's because it's wrapped up in a plastic wrap, that gown, and it's, in a bag, the mask. So they can bring that to their next client if that's what they're doing, or they'll go back the next day to the same client. We've sort of said caregiver keeps their own PPE supply whole. In terms of burning through it, I think it's a matter of education. Ask them why they're burning through it. Why? What's happening that you are burning through your PPE so quickly? Is it something we're doing? Is it something you're doing? Is it just a misunderstanding that like every time you like, you know, walk into the kitchen, you have to change this or that? Like you might just want to find out why it is that they are burning through it. We have not had that problem, but maybe no one's telling us. You know, I never know. I mean, I'm just assuming we're doing it okay, but you know, I think that the 4-hour rule where they get 1 packet per 4 hours seems to be the way to go for our agency so far. And then I give them a little extra. Next.
That's great. Thank you. Thank you, Amy. So the next question is from Rose. Do you have powered air purifying respirators for extended visits?
Oh, such a great question. So to that end, those are about $280. So I looked into this, and if you add up the costs, so I just want to let you know, you're not so off by thinking that, because they're actually, if you look at like a extended period of time, it's probably more cost efficient in some ways to have a popper or PAPR, whatever they kind of call it. I think they were like $280 or $300. There is probably a role for that. And I did think about it and have not stopped thinking about it actually, because they are much more comfortable, and the cost of supplying that individual who might be doing a bunch of 12s is probably not so, it's not so unreasonable. We just haven't moved forward with it, but it's not a terrible idea, and I did think of it. So great mind.
That's a great answer. The next question is from Caitlin. This, I think you've answered it already, but let's see if you have anything to add. How did you address staff or paraprofessional staff who were utilizing their PPE faster than you could replenish it? Did you not replenish it? And were they on their own once you had supplied them weekly or biweekly?
So within our agency, we would just supply them back up and try to figure out what was going on. We haven't really had that be a problem. But I can tell you, if it did become a problem, I would just, you know, ask them what's happening. How is this happening? And then of course we would resupply them up. We do not have any of our caregivers supply their own PPE. We supply everything for them.
Okay,
it's the cost of doing business.
We have a question from Kelly. How are you monitoring that staff are using the PPE correctly in their home? She's not able to do this in person audits. So do you have ideas about how to make sure they're using it properly?
Such a great question. So of course we have some RNs who do, the 45, whatever the law is. I always forget what it is. You know, they have to do the visits, and we do they do drop-in visits without announcement to see that the caregivers are wearing the PPE. We have found that sometimes they're not doing it, but we get wind of it and then we re-educate. So yeah, you have to monitor it. I mean, you could have people check in and, do a visual on them, but look, I actually have friends who have caregivers from not a JESA agency, but from a different agency. And I know that those caregivers have been given PPE and we know that they're not wearing it. It goes back to sort of real life challenges. We don't live in a vacuum. We don't live in a perfect world where everyone's going to buy into this idea, and their job is so hard and so challenging, and it's very uncomfortable. N95 masks are not comfortable, period, end of story. It's just, they're not. And, it's hot with the face shield and the, things fog up. I mean, it's tough, but you can use, if you use some nurses who are going out to do change in condition visits or, pop-in visits for re-education, that's really your only choice. I don't think there's a magic bullet there.
Okay, that's fair. So we had similar questions. Ada had the next question, but Gracie asked a similar question. How did you pass the cost of providing PPE onto your clients? Was there resistance? And do you pay caregivers a hazard rate?
So great question. So the first question I'm going to answer by saying we have not passed this cost along to our clients. We are a nonprofit, so we have that benefit of having some donated money that has allowed us to not pass that cost along. But in a brief, like I've shopped a few other agencies, and some people are probably even on this call, they're like, Amy called me about that. My understanding is there hasn't been a lot of passing that cost along, but I don't know that that isn't going to happen creeping forward. And I think a lot of agencies were like, we don't want it to affect our ability to get new clients in, but over time you're going to look, it's going to completely affect your bottom line. I think it's going to be an absolute necessity. And I think we did like a little straw poll of some of our clients and said, if we were to pass this cost along to you, how would you feel? And they were like, that's fine. Like, I think everybody kind of understands. The problem is when it increases the cost, like if you say, let's just say it's $5 per 4 hours to supply PPE. And so that for an 8-hour shift, that suddenly it's $10. I mean, it's basically increasing your cost of doing business by about $1.10 per hour. I mean, I think if you say it like that, it probably, I mean, I'm not the marketing genius, but I think that doesn't sound so unappealing, especially if you're like, we're here to protect you from us and we're here to protect us from you. So it seems to, I think there's some way to sell it so that it doesn't sound so onerous. And I think, we're in the middle of a pandemic. I think what would have worked 3 months ago would not work 2 months ago, would not necessarily work now in terms of communicating that. And then what was the next part of that question?
The next part of the question was, are you paying caregivers a hazard?
Right. So we utilized a hazard pay mentality when we had the stay-at-home orders. Yes, we did do hazard pay. We are not doing hazard pay now, but if somebody has COVID, we do hazard pay. If we have a known COVID patient, we're doing so much testing now that we know. Like if a client's coming out of the hospital, they've usually had 2 negative tests, so we know. And our client base is different than some other people's client bases. We have a lot of people coming directly out of facilities, so we really are getting a lot more information with each new client intake. So before we just said everyone has COVID, so we gave everybody hazard pay at the beginning for the stay-at-home, and that we are not doing hazard pay right now. And I'm sure a lot of folks still are, and I applaud that, but we're not. Okay.
Okay, next question. Robert wants to know if there are any Maryland state resources assisting Maryland agencies.
I know MNCHA had some things going on. I think it's important to know this. This is gonna be a statement not so much about PPE, but about testing. And because I really, honestly, we had access to PPE that was made through some organizations that our agency is a part of. So, I completely empathize with the ability to get PPE. And at one point we weren't getting that supply, and I actually went over to, was it Dennis Avenue or wherever the health department is in Silver Spring to try and pick up PPE because I'd gotten an email that it was going to be available on a Saturday, and I dragged my husband out and they were like, oh, I'm sorry, all we have is bleach for like daycare centers. And I was like, why did I get this? And you sort of drive around like a mad person. I don't know if MNCHA still has a big old supply closet that they're able to supply people from, but I don't know of a very reliable supply chain that's free.
Well, I can jump in there. I think Dawn Seek, the executive director of MNCHA, is on the call, but MNCHA is doing bulk purchasing of PPE. And if anyone wants any more information about how to partner with MNCHA around that bulk PPE purchasing, just reach out to Dawn Seek at DSEEK, so Dawn Seek, DSEEK, at MNCHA, MNCHA.org. Again, DSEEK at MNCHA.org. Okay, that's it. Do you have other things to add for Robert's question about other Maryland state resources?
So yeah, let me just tell you guys that if you live or work in Montgomery County, they are now providing free COVID testing. And I will be happy to pass along the resource to you. Your agency has to get registered with the county, and the testing is PCR testing and it is spit testing. And I'm sure you're going to all bombard me later with this question, so I will be sure to to give it to Dr. Brown and to Nussin to make sure that they can communicate that. But we have just sort of gotten on board with that because we are going to implement, testing throughout our entire agency on a regular basis. And I think that's actually a great marketing strategy too. Hey, listen, we're all tested, we're all good, that kind of thing. I think it's really reassuring. I'm not sure that it will keep me from putting all of my caregivers in full PPE, but at least I'll know I'm not giving it to them, and it will allow me to get into more facilities.
That makes a lot of sense, Dr. Schiffman. I have an update from Dawn Seek. They are not bulk purchasing, but making vendor information available to agencies. So still reach out to Dawn if you have questions about that. She's there to help. Steve had a question. So if a caregiver is working 3 12-hour shifts per week and you're providing 12 packets a week, are you expecting that the caregiver is changing out the PPE every 4 hours?
Great question. So your math is correct, and that is how much we supply. I am giving them what I think if they were to change out their PPE. I mean, some people are going to wear their mask the whole time, and that makes sense, but they're going to have extra masks if something were to happen. And in terms of the gowns, that's where I think a lot of the changing is going to happen. And people go to the bathroom, they go outside, all sorts of stuff happens. So I think there is a very high possibility that somebody would be changing their gown every 4 hours.
Okay, thank you. We have some similar questions from Ada and Daphne about reuse. So is it safe to reuse PPE the next day? What if I wore scrubs to do one visit, and then changed them and washed them after the one visit? So
that's right. So scrubs that you're wearing underneath your PPE, fine. But remember, your PPE, your scrubs are moving around with you, right? So you're bringing them wherever they are. And it's just going to increase the chance that you yourself are going to get COVID. Remember, the PPE is to protect them, and it's to protect you.
And one thing, I think I combined the questions when they were really separate questions. So first, is it safe to reuse the PPE the next day, period? So that would be like your mask. And
so I'm happy to direct you to the CDC guidelines for how to clean an N95 mask. But in terms of if you're taking care, so the question really is you're taking care of the same client and you're just going in each time with the same mask. I mean, we're being very conservative. So we're having them toss everything, right? Because in order to reuse PPE, assuming that person has COVID, right? You go with the assumption everyone's got COVID, you got to store that mask a certain way, you've got to doff it and don a certain way, you got to clean it a certain way. It's a very different kind of thing than throwing it away. So for sure there's no reason to ever reuse a gown, right? And gloves. And you can certainly reuse your face shield, but you should clean it, assuming that person has COVID. And in terms of the mask, we personally are supplying everybody with a new mask for every different patient encounter. But there are ways of cleaning an N95 mask, and you can see those on the CDC website.
And I'll make a plug here. On July 23rd, we're going to have Dr. Roy McKay as a speaker, and he's literally one of the nation's experts on N95 and other respirator masks. So if you come back then, you can ask him anything you want to know about reuse of masks or N95 masks, fit testing for masks, fit testing for N95, and so on. Great. Okay, so we have another question. Caitlin wants to know, what new client screening practices do you use for your private duty business? What if new clients cannot produce a negative result prior to initiating service?
So everyone's got COVID. That's our premise. Everyone's got COVID. So we just assume that everyone's got COVID and we put everybody in full PPE. In terms of screening, we do, we get a lot of information about people. I'm trying to think we do screen our caregivers with every shift. In terms of the clients, we just do a deep dive. We have crisp access, that kind of thing. So we are able to figure out if they were tested, but if they're just showing up from their house and we don't know, they've got COVID until proven otherwise, I guess. Can't screen everybody, just got to put everybody in PPE.
Yes. Are you implementing weekly testing?
We are.
All right. On the testing note, are there any healthcare provider only testing sites?
No, but the state of Maryland, I'm sorry, the county of Montgomery County, I am pretty sure that this testing thing that we're getting involved with is really directed towards healthcare providers. I actually didn't even ask, like, if you're working in a law firm, can you just go get tested? I don't know. It may just be for healthcare providers. But again, I will be sure to pass that information along to Dr. Brown and Nussin so everyone has that.
Okay, great. How often, Kelly wants to know, how often are you currently testing your caregivers with the free testing you mentioned?
Oh,
are caregivers able to go weekly?
We're rolling it out and it's going to be weekly.
Okay, wonderful. Gracie wants to know, she says hospital ERs are using the same N95 for 3 full shifts with multiple patients. Didn't the CDC change the guidelines?
So what once was not now, but I can tell you, the access to PPE was very bad at the beginning. It was terrible. So they had to wing it. Like if you would, I'm an ER doctor by training, right? So like never would I have ever been like, oh, you know what? Not only am I going to wear this mask with every single patient, but I'm going to take it home with me. And then I'm going to bring it back to work the next day. So whatever that was may still exist in some emergency departments. I don't really know what the status is anymore. There was a real dearth of supply and people were in it was a very different way. And they were having to like basically figure it out, you know, and deal with limited supplies. I don't really know that that's the case anymore. Maybe you have a lot more information than I do, but you know, my understanding is that people are wearing new N95s.
So this again is a great question for Dr. McKay on July 23rd, but there is, you know, I'm also a physician and N95 masks were not meant for reuse, but in the context of an emergency, guidelines have changed and there are contexts in which reuse makes sense, especially given the shortages and to prevent future shortages. But the context for a hospital seems a bit different than the context for a private duty home care agency. Let's save these questions for Dr. McKay. I'll actually send them to him ahead of time so that he can address them head on during his talk. We have a question from Linda. Hi, Linda. Can you speak to the Montgomery County testing? Is it that the kits are free and the test processing is under each person's health insurance?
So yeah, I'll just tell you what I've learned. And again, I will give you the resources, but the idea is that they will try your health insurance if you have it. If it gets bounced back, they will cover the cost. So even uninsured and health insurance that will not cover for asymptomatic patients, they will cover that cost. I called it like an all-you-can-test buffet. The turnaround time is not great, just so that you know, yet. They're working on that.
Okay. Caitlin has a follow-up question. So how do you address fill-in shifts for private duty if packets are prepared in advance? Are they given extra?
They are. So like I said, we give out a little bit extra with every single pack. And, you know, we also have an ability to get the supply to somebody if they don't have it in advance because we use our internal resources. Yeah, it's a resource intensive process. Nothing easy about it.
Okay, we have a follow-up question from Ada. What about your staff in the office? What are the guidelines regarding the use of PPE in the office?
So everybody has to be wearing a mask at JESA. We have very few people back in the office. Almost everybody is working remotely. We have only like 3 people in like this giant, enormous office building. So we don't have many people in the office. So as much as you can figure out how to work from home, you should do that.
Okay, and the ones in the office, are they wearing masks?
Yep, they sure are. It's required in the building.
Excellent. Okay. We have a couple of comments that I'll read out loud from Dawn Seek, the Executive Director of MNCHA. So she said that there is a free service to clean N95s. And again, you can follow up with her to learn more, dseek@mncha.org. And I think that's it. The questions were coming in fast and furious, but they have stopped. Does anyone have any more questions? We have just about 3 more minutes. We can squeeze in another 1 or 2.
And then we want to make sure we do our other poll, right? Do we have another poll?
Yeah.
Yeah.
Why don't you go ahead while we're waiting to see if there are any more questions? Nasim, why don't you go ahead and put up the final poll? We just want to get your feedback on what information from this talk was useful so that it can help help to inform how we approach these talks in the future. Also, while the poll is up, I'll just do a couple of plugs for our upcoming webinars. So on Thursday at 5 p.m., we are meeting with Dr. Lisa Fitzpatrick and Amma Adepa-Grin. Amma is a CNA who's worked in home care for years, and Dr. Lisa is an infectious disease physician. And we're going to talk about misinformation about COVID-19 in the community. There are a lot of myths that are circulating, and trust me, your caregivers and staff believe some of them. So there was a myth that if you drink hot water, you'll be able to kill the virus. Some caregivers believe that they'll get CO2 poisoning if they wear a mask all day. There's lots and lots of information that isn't really going to be covered in a typical COVID-19 training on PPE or on just COVID-19. So if you want to come and hear what the word is on the street about the myths circulating about COVID-19, join us and just register on the EPN website, mdemergencyprepnetwork.org. Just go to the events tab. On July 23rd, we have Dr. Roy McKay, who is, again, one of the nation's expert on N95 fit testing and respirator masks of all types. It's a great place to ask your question about poppers, and just a lot of these questions will be excellent to bring to him as well. On July 30th, we have Dr. Clifford Mitchell from the Maryland Department of Health. He's director of the Office of Environmental Response, and he is phenomenal. He's going to talk about how do you think about managing chronic diseases in the context of COVID-19? So you still have to take care of your patient's actual health problems in home health care. He's going to talk through some of the considerations for COVID care through the routine care through the lens of working in a COVID-19 environment. So that's what we have on deck for July. We hope that you'll keep coming to join us. I think by now, everyone should have answered the poll if they're going to answer it at all. So we can take down the poll. I'm doing a quick scan to see if there are any more questions, and there are not. So thank you for coming to our inaugural webinar. Dr. Amy Schiffman, you did not disappoint. You were amazing. I contacted Dr. Schiffman because I had heard through the grapevine that she had taken a very scientific approach to the use of PPE for JESA, and I really wanted her to be able to share that with everyone else. And so thank you again for taking the time to walk through your experience. We are lucky to have you. And with that, everybody, if there are no more questions, oh wait, something popped up. Wait, what is it? Let's see. No, it didn't. That's weird. Huh. I think that's it. I think we covered it all. If you have any follow-up questions, just let me know. Thank you for everything. And we're gonna close out the webinar. Have a great rest of your day.
Do we get to see the results of the poll?
Oh, pull it up. Let's see.
Yeah, pull it up. And then I want to put in one last plug. Well, let me look at this, and then I want to put in one plug for something fun that I've been doing. And anybody who's on this knows me, I'm always got something fun on the side. So let's see, 55, how we distribute PPE. Okay, so that seems to be the winner of what people are going to take home from here. Interesting. So, you know, as the Chief Medical Officer of JESA, that is my full-time gig, but I started a podcast. If anyone's interested, it's called Mastering Medicare. I made a project I've done with Dr. Alex Moseni, who is one of our, who's another local emergency physician who does telemed. Anyways, if you go to your Apple or to Spotify, you can find it on, it's called Mastering Medicare. So if you need to learn about how Medicare Part A, B, and D work, that's a good place to go. That's my little fun plug.
All right, everybody, did you get that? Mastering Medicare.
Mastering Medicare podcast. I figured I'd put it out there. Why not?
When is the next podcast coming out?
So we have, I think we have 12. We've dropped 12 so far. So you have like about a good 12 hours of listening. We're trying to put out once a month at this point. It's a little harder in COVID, but we have something about MOLST forms. But I think the first four are like a really good basic to the introduction to Medicare. Everybody who has ever worked in my practice or who I work with has heard these talks, and I did it in the form of a podcast with Dr. Moseni. I think we're pretty funny, so.
Fantastic.
Make something really boring kind of interesting.
I think it's phenomenal. And as we can tell, Dr. Schiffman is a woman taking care of many important things. I want to give a shout out to Nasan Wiseford, who is quietly behind the scenes making this webinar happen, handling the tech. So thank you, Nasan, for all that you do. And also Dawn Seek. And of course, again, a final shout out to the Maryland Office of Preparedness and Response for making this possible. We are grateful to your leadership, and see you on Thursday. Okay, bye-bye, everybody.